Okay, this is a 52-year-old female with a lot of problems. She had a right microphthalmia with phthisis bulbi and deafness since childhood, pathologic myopia in the only functional left eye, nystagmus, and the patient was not rehabilitated. Therefore, she does not speak or communicate easily. She presents to my office with acute decreased vision in her only functional eye, noticed by her family due to loss of mobility and bumping into objects. I diagnosed a posterior pole retinal detachment. It was flat with no identifiable causative lesion, and the plan was a cataract surgery with intraocular lens, 360-degree scleral buckle, vitrectomy in the left eye. I used triamcinolone to see all the vitreous and contact lens with high magnification. This is the surgery. At this point, I did the cataract, the scleral buckle, and I did the vitrectomy and the shaving of the periphery. I like said before, the triamcinolone, and I was ready to do my peeling because I thought the causative lesion was a macular hole. When I was in the temporal side of the peeling, I found these remnants of cortex vitreous, that it was not, found before. I realized that I didn't, remove all these remnants until I put this contact lens with magnification. I remove all these vitreous in the posterior pole. Then I finished my peeling at 360 degrees around the fovea. I did it in a foveal sparing form. Then I trim the tips of the ILM. And then I changed the lens to a wide angle lens to see the periphery, and remove all the vitreous with bimanual technique with the vitreous cutter and the forceps, as periphery as I can. And then I found a small hole in the border of the optic nerve. I did my exchange fluid, air fluid exchange, and then silicone oil. Can I see my last,
Can we have the slides again,
slide, please? And the key takeaways is that in patients with poor contrast, it's better to use triamcinolone or this contact lens with high magnification to remove all the cortex vitreous remnants and to minimize the risk of recurrent retinal detachment. I see in the presentations before that here you use a lot of triamcinolone. In Mexico, it is not a standard care, but I like to use it in redetachment or in myopic patients to avoid these things. The patient was fine. Maybe if I left all these remnants, I will have a retinal redetachment, but the patient is okay now. Thank you very much.
Thank you very much.
Thank you. Any questions?
Great surgery again. And it was a pathologic myopia case. The fellow eye was microphthalmic. This eye was degenerative myopia. So there should be something behind. So from maybe a congenital thing.
Maybe, but I don't know that the patient was she was not able to speak. She was not rehabilitated, and the parents, they were like very, I think, with poor resources, and we don't know what happened, but it was her only eye with myopic changes and retinal detachment, and
It's very common to see, many layers of membranes in pathologic myopia, and it's so wise to use triamcinolone again and again and also some dyes, maybe like brilliant blue, to when you peel the ILM, you make sure that there's no remaining vitreous schisis or epiretinal membrane. So you did a great job.
Thank you very much.
Any other